So this is our fourth lecture in the respiratory package, ventilation basics and modes. And I'd like to introduce you to Elsa Afonso. And Elsa is undertaking a PhD at Gwent University in Belgium and is a senior lecturer in nursing at Anglia Ruskin University in Cambridge. Thank you, Elsa, for coming along today to present. I'm really looking forward to your talk.
Thank you very much, Una. Hello and welcome to the session on ventilation basics in the intensive care unit. This session will attempt to cover the essential information you should have as a non-ICU nurse. It is not intended to give you in-depth knowledge on mechanical ventilation, but will try to enable you to understand key elements around ventilation, ventilation modes, and how to care for a ventilated patient. So by the end of this session, you should be able to recognize which patients are in need of mechanical ventilation in the UK, in the ICU, grasp and apply important concepts around respiratory anatomy and physiology to mechanical ventilation in the ICU, understand and comprehend the invasive and non-invasive ventilation modes, and finally understand what are the essentials of caring for ventilated patients and the most common ventilator-associated complications. First of all, it is important to understand why is it patients in the ICU will most likely need artificial ventilation. And in general, mechanical ventilation is indicated whenever a patient's spontaneous breathing is not adequate enough to sustain life. Patients who need mechanical ventilation will be some form of acute respiratory failure, perhaps some form of alternative non-invasive method of breathing support will not be enough to help them recover or will have failed. This temporary replacement of the patient's own ventilation may be planned as part of, for example, a post-operative need, or it might be urgent in view of imminent severe respiratory failure. And we will describe the types of respiratory failure, which will be essential to introduce us as to how the ventilator helps the patient. However, I first want to briefly cover some aspects concerning normal respiratory processes, such as physiological breathing mechanisms and some concepts around lung volumes and gas exchange. So to start with, let's talk about pressures in the lungs and how the lungs breathe. Pulmonary ventilation is dependent on three types of pressures: atmospheric pressure, intraalveolar, and intrapleural. Atmospheric pressure equals to 760 millimeters of mercury, or 1 atm, which is the atmospheric pressure at sea level. Typically, for respiration, any other pressure values are discussed always in relation to atmospheric pressure. Therefore, negative pressure is a pressure that is lower than atmospheric pressure, whereas positive pressure is pressure that is greater than atmospheric pressure. A pressure that is equal to atmospheric pressure is expressed as zero. The intraalveolar pressure, the pressure that is inside the alveoli in the lungs, is the pressure of the air within the alveoli, and it changes during the different phases of breathing. Now, because the alveoli are connected to the atmosphere via the breathing pipe, by the tubing of the airways, the interpulmonary pressure of the alveoli is always equal to the atmospheric pressure. Intrapleural pressure, which is the pressure of air within the pleural cavity between the visceral and parietal pleurae. And similarly to the intraalveolar pressure, intrapleural pressure also changes during the different phases of breathing. However, due to certain characteristics of the lungs, the intrapleural pressure is always lower than or negative to the intraalveolar pressure, and therefore comparing it also negative to the atmospheric pressure. Although it fluctuates during inspiration and expiration, intrapleural pressure always remains approximately -4 millimeters of mercury throughout the breathing cycle. Apart from pressures, there are physical factors affecting ventilation. The lungs themselves are passive during breathing, meaning that they're not involved in creating the movements that generates inspiration and expiration. The thoracic wall recoils during expiration, causing compressions of the lungs, and contraction and relaxation of the diaphragm and intercostal muscles, which are the main muscles involved in breathing. result in expiration, and these muscle movements and subsequent pressure changes within the chest wall cause the air to either rush in or be forced out of the lungs. So we can say that pulmonary ventilation is driven by the differences in pressures because air flows down a pressure gradient. That is, air flows always from an area where the pressure is higher to an area where the pressure is lower. And it flows into the lungs largely due to differences in pressure. Atmospheric pressure is greater than intraalveolar pressure, and intraalveolar pressure is greater than intrapleural pressure. So air flows out of the lungs during expiration based on the same principle. A pressure within the lungs becomes greater than the atmospheric pressure. Pulmonary ventilation comprises two major steps: inspiration and expiration. Inspiration is a process that causes air to enter the lungs, and expiration is a process that causes air to leave the lungs. The respiratory cycle is one sequence of inspiration and expiration. The process of normal expiration is passive, meaning that energy is not required to push air out of the lungs. Instead, the elasticity of the lung tissue causes the lungs to recoil as the diaphragm and intercostal muscles relax following inspiration. In turn, the thoracic cavity and lungs decrease in volume, causing an increase in interpulmonary pressure. The interpulmonary pressure rises above atmospheric pressure, creating a pressure gradient that causes air to leave the lungs. This mechanism, we say that it's negative pressure ventilation, and this is going to be important to understand why we call mechanical ventilation positive pressure ventilation. Having understood the main breathing mechanisms, I just want to introduce you to the main volume concepts that are involved in the breathing cycle, because this will help you understand the terminology used in mechanical ventilation. Tidal volume, TV or VT, is the amount of air that normally enters the lungs during quiet breathing, which is about 500 milliliters. Expiratory reserve volume is the amount of air that you can forcefully exhale past normal tidal expiration, which usually for men is 1,200 milliliters. Inspiratory reserve volume, IRV, is produced by a deep inhalation past the tidal volume inspiration. This is the extra volume that can be brought into the lungs during a forced inspiration. Lastly, residual volume is the air that is left in the lungs if you exhale as much air as possible. Residual volume is important because it makes breathing easier, and it prevents alveoli from collapsing. And respiratory volume is dependent on a variety of factors. Measure different types of respiratory volume, which the ventilator does, and we will see that, can provide important clues about a person's respiratory health. Finally, let's talk about gas exchange. Gas exchange occurs at two sites in the body. In the lungs, where oxygen is picked up and carbon dioxide is released at the respiratory membrane, and at the tissues, where the oxygen is released and carbon dioxide is picked up. We will talk about external respiration, because it happens at the lungs, and that's what we're interested in at the moment, is the exchange of gases with the external environment, and it occurs in the alveoli. This is an image of an alveoli to kind of make you understand how it happens. The actual exchange of gases occurs due to simple diffusion. There is no energy involved in diffusion of gases in the lungs, in the alveoli. These gases follow pressure gradients allow them to diffuse. So the anatomy of the lung maximizes the diffusion of gases because the respiratory membrane is very permeable to gases. Respiratory and blood capillary membranes are very thin, and there is a large surface area throughout the lungs to allow this to happen. Its external respiration occurs as a function of partial pressure differences, as I said, and it's determined by three factors. Ventilation, commonly mentioned as V, which is related to the size and efficiency of the breath. Perfusion, which is commonly referred to as Q, which is associated with the type of pulmonary blood flow. And finally, diffusion, which is the simple movement of gases across tissue between the pulmonary blood flow and alveolar air. Having mentioned the main normal processes associated to how we breathe and how gas exchange occurs, we can now start going into what makes patients require mechanical ventilation in the ICU. And as we said before, ventilation in the ICU is needed when there is some form of acute respiratory failure. And there are two main types of respiratory failure. One is related to a failure in ventilation, and the other is related to a failure in oxygenation. The reason why we need to have this baseline understanding is because the ventilator will be set up differently depending on the type of respiratory failure that we are facing. So an example of a type 1 respiratory failure are diseases that increase distance between air in the alveoli and pulmonary blood flow, inhibiting transfer of oxygen, such as, for example, pulmonary edema. Examples of type 2 respiratory failure are diseases which inhibit the breath size and efficiency of breathing, such as neuromuscular weakness, bronchoconstriction, COPD, or extensive alveolar damage, such as emphysema or ARDS. The objective of mechanical ventilation will depend, hence, on the type of respiratory failure. If there is an oxygenation or type 1 respiratory failure, then we need to improve the function of the exchange of gases at the alveoli level. So we will look at optimizing mean airway pressures, adjusting inspiration time to allow more oxygen to enter the alveoli, and keep positive end expiratory pressures constant to allow more time for gas exchange to occur. If there is a type 2 ventilation, a respiratory failure, which is a ventilation failure, then we need to improve the ability of the lungs to excrete carbon dioxide. So basically, we will look at optimizing tidal volume so that we improve lung expansion to excrete more carbon dioxide, and adjusting expiratory time, frequency, or respiratory rate, and the flow of the breath to allow more carbon dioxide to exit the alveoli. Manipulating these factors will allow that allows for improved ventilation while trying to minimize the negative impact of the ventilator. Because despite life-changing, ventilators are dangerous if they are misused, and mechanical ventilation can cause lung damage from excessive airway pressure, which we call barotrauma, and also volume trauma. Let's start talking about equipment before we talk about ventilation modes and about the patient care. As an introductory note, it is important to note that historically ventilation can be divided into two main types: negative pressure and positive pressure ventilation. Negative pressure ventilation was, not surprisingly, because it is the most physiological type, the first form of mechanical ventilation. In an attempt to mimic normal negative pressure physiology associated to normal breathing that we spoke about before, negative pressure ventilators were literally iron compartments where patients were placed. The iron lung, as they were known, was widely used in patients suffering from polio and botulism and are at the moment medically obsolete. They were replaced by more modern modes of ventilation, namely called positive pressure ventilations. And these are the ventilators that we will see being used in modern ICUs. And despite big differences in appearance, depending on the country, the city, the hospital, and even the type of ICU and the brand, all mechanical ventilators have several basic features in common. All must be connected to high pressure sources of oxygen and air, either an outlet on the wall or an oxygen and air cylinder. Once the gases enter the ventilator, they're blended to produce a fractional inspired oxygen concentration, or FiO2, which is set by the person who sets the ventilator. At the onset of inspiration, this pressurized gas flows through a heater and humidifier, through an inspiratory limb of the ventilator circuits, through the endotracheal tube, and into the patient's lungs. Exhaled air travels back to the ventilator through the expiratory limb of the ventilator circuit and passes through a filter before being released to the atmosphere. Volume and flow are measured each time the gas leaves and returns to the ventilator. Mean airway pressure is continuously measured within the ventilator circuit. All ventilators have a user interface, which includes a video display. This user interface is useful for two reasons. It allows the user to choose ventilator settings and display these settings. Also, on the left, you've got the main settings of a ventilator, and on the right, you've got the main readings of the ventilator. And they're different, but they provide important real-time patient readings to help patient information to help monitoring the effect of the ventilation. It is useful to get familiar with which one is which, because this information will be the one need to be monitored regularly by nurses. Essentials of mechanical ventilation will include first some more important concepts and then basic modes of ventilation and some of the settings that try to make ventilation more patient-friendly. This is some of the terminology that you will encounter when caring for ventilated patients. They will play together in the moment of deciding which mode or setting is best for each patient, and the senior clinical team will be using their expertise to apply and read them appropriately. Mean airway pressure, or MAP, typically refers to the mean pressure applied during positive pressure mechanical ventilation. Inspiratory time and expiratory time are often is the time that the patient takes for the air to go into the lungs and out of the lungs. And often you'll see this expressed as a ratio, an IE ratio. Considering the breath cycle is 1, the bigger percentage towards expiration or inspiration will determine how longer we want the patient to breathe in or breathe out for. Your PEEP stands for positive and expiratory pressure, and it's the pressure that is remaining in the airways at the end of expiration, and it's usually around 5 centimeters of water. FiO2, the fraction of oxygen that is delivered by the ventilator. Tidal volume, it's the volume that goes in and out of the lungs in each breath. Minute volume, which is the air that goes in and out of the lungs in 1 minute, and it is important because it associates tidal volume to breathing rate. Your respiratory rate, which is usually around 15, but it can range from 12 to 20, plateau pressure and driving pressure. And the plateau pressure is a maximum pressure that a ventilator expands the lungs, and the driving pressure is a differential between this maximum pressure and PEEP. There are several modes of mechanical ventilation. Depending on the unit that you will be working on, they might be different, they might be called different, but the basic functioning will be the same, or the main factors associated to these modes will be the same. And I've enumerated them from the most simple to the more complex, and they are the following. Well, we will explain what they mean afterwards. CMV, PRVC or APV, SIMV, ASV, NAVA, and these are the more mandatory modes, or the less spontaneous modes. We have then more spontaneous modes, allow the patient to do a little bit more work, called ARPV, PSV, CPAP, or bilevel. Starting with CMV. It stands for controlled mandatory ventilation. It was the first positive pressure ventilation mode. It essentially controls the patient breathing, and it is used when the patient is not doing any respiratory effort. The ventilator delivers either a set pressure or a set volume of pressurized air at a certain rate and IE ratio. In modern ventilators, CMV can be pressure limited to prevent excessive pressures being delivered. Just to make it clearer, most ventilation modes can be guided either by pressure or volume, and CMV is a good way to explain how this works. In these two graphs that represent a ventilator delivering CMV to a patient, we can see that the first one is pressure control, meaning that we have set a pressure limit to the air that is delivered to the patient's lungs. This will mean that in every breath, there will be different volumes achieved in the lungs. On the second picture, we see a patient ventilated on CMV with volume control. We have told the ventilator that the patient needs a specific volume to be achieved, and that it can deliver any positive pressure necessary in order to achieve those volumes. This alone is dangerous because there could be too much pressure being delivered that could cause barotrauma. Now, this is important to understand the next mode, which kind of attempts to prevent this. PRVC, which is pressure-regulated volume control or adaptive pressure ventilation. In this mode, pressurized air is delivered at a set rate to achieve a desired tidal volume with variable pressures. However, pressures can be limited by the user to prevent barotrauma. Depending on the ventilator brand, patient-initiated breaths are fully supported by the machine. So you can imagine that in patients who are tachypnic for other reasons, this can lead to hypertension or hyperventilation. This next mode, SIMV, standing for synchronized intermittent mandatory ventilation, is similar to PRVC or CMV. The difference is that it synchronizes with the patient's respiratory efforts in order to prevent that hyperdistension and hyperventilation. ASV, or adaptive support ventilation, is a mode in which various settings, such as respiratory rate, tidal volume, minute volume, inspiratory pressure, expiratory pressure, the ratio of inspiration and expiration, are adjusted by the ventilator in order to maintain a certain minute volume. If the patient doesn't breathe, the machine delivers pressurized air to ensure appropriate ventilation. On the other hand, if the patient breathes, then it supports and optimizes the breaths. It is sometimes used when we are weaning from mechanical ventilation. NAVA is a mode that is not used in all settings, and it stands for neuronally assisted ventilation. In this mode, the ventilator measures the electrical activity in the diaphragm through a special nasogastric tube. This measurement is then transferred to the ventilator to trigger ventilation. Now, these are more spontaneous modes that I'm going to mention from now on. So airway APRV, airway pressure release ventilation. In this type of modes, desired minute volumes are set according to ideal body weight of the patient. What distinguishes this mode from the others is that patients may trigger all the spontaneous breaths at two different pressure levels, and this is called kind of pressure support. And they can trigger the breath at two different levels, a high pressure, which promotes lung expansion, and a low pressure, which promotes CO2 clearance. PSV, or pressure support, is a self-ventilating flow cycled mode. So once the patient triggers a breath, pressure support delivers a gas until the set pressure is achieved, and it adds volume to non-effective breaths. Hence, it compensates for any muscle weakness that the patient might have. To use this mode, the patient must be having some sort of spontaneous breaths, and it can be used alone or often used as a complement to other modes, and it's one of the most commonly used modes. I will refer to CPAP and bilevel ventilation together because they're similar and also be referred as non-invasive ventilation modes following this. CPAP is a self-ventilating form of providing PEEP, positive end expiratory pressure, and it is available on most ventilators, even though usually when the patient still has an ET tube, bilevel or BiPAP is more commonly used. Bilevel positive airway pressure is essentially like alternating two different CPAP pressures, an inspired positive airway pressure and an expiration positive airway pressure. EPAP, expiratory pressure, provide all the benefits of PEEP CPAP, while the IPAP, the inspiratory pressure, increase the tidal volume. BiPAP is essentially the brand name for bilevel, but you'll see it being used in a lot of settings. Because in the context of mechanical ventilation, CPAP and bilevel are considered the most spontaneous modes, it makes sense now to explain that they are also considered non-invasive methods if they are delivered not by an endotracheal tube, but through a facial device. Non-invasive ventilation can be applied to any patient that presents with all these conditions, but who has respiratory drive. The decision between using invasive or non-invasive ventilation is made by the senior clinical care team and will rely on several factors. Essentially, both CPAP and BiPAP or bilevel can be delivered through machines that generate positive pressure through a flow of air. And these devices are applied to the patient via different interfaces, and this depends on the patient and the manufacturer. With CPAP, continuous positive airway pressure, only EPAP, expiratory positive airway pressure, will be delivered, and it's usually between 4 to 5 centimeters of water. Airway pressure is maintained on expiration only, keeping the airway open and allowing the alveoli more time for oxygenation. With BiPAP, or bilevel positive airway pressure, both EPAP and IPAP are delivered, expiratory and inspiratory airway pressure. Airway pressure is maintained on expiration and inspiration, keeping the airway open and supporting hence both oxygenation and ventilation. This graph might help understand what happens with non-invasive positive ventilation in comparison to normal breathing. So you can see here that while CPAP maintains the same pressure throughout the entire cycle of breathing in and breathing out, and maintains a certain PEEP, which will keep the breathing cycle going at this PEEP level. A BiPAP machine, in contrast, besides giving PEEP on expiration, will deliver a higher pressure during inspiration. And this inspiratory pressure drive will be higher or lower depending on what the patient needs. If the patient is getting better at breathing in, the pressure differential will be minimal, and this mode will be more and more similar to CPAP. Essentially, CPAP and BiPAP prevents airway collapse and reduces respiratory effort, acting as a splint. There are several ways in which CPAP and BiPAP can be delivered. Via nasal mask and facial mask are the most common ones. And here you can see some of the methods that can be used to deliver CPAP and BiPAP. Having said that, and despite having less complications than invasive mechanical ventilation that is delivered through an endotracheal tube, CPAP and BiPAP are not entirely short of side effects. The severity of the side effects is usually associated to the intensity and duration of the treatment, and also the underlying condition or fragility of the patient. Mainly, it can cause problems like local skin damage or pressure ulcers from the mask or the other, or any facial interface that is being used. Mild stomach bloating due to the high volumes of air being pushed into the lungs and hence into the stomach. Claustrophobia that can be quite uncomfortable. Dry mouth. Leaking from the mask, causing less pressure to be delivered. They're quite dependent on positioning, hence on nursing care. Eye irritation and sinus pain or sinus congestion due to drying up of the airway. So regular patient observations are necessary to prevent, identify, and intervene as early as possible. Now, this last mode is not mechanical ventilation, and it's not a mechanical ventilation method. It is essentially oxygen therapy, but it is important to talk about it because it has been recently more and more popular, more popularly used in the ICU, and it is efficient and it is comfortable. So similarly to non-invasive devices, it is only to be used in patients who are breathing spontaneously. And it is a mode of oxygen supplementation. It is always non-invasive, and delivery of this mode is done via nasal prongs. A good way to remember what high flow does is a mnemonic, high flow, meaning that air and oxygen mixed from the wall or cylinder is heated and humidified, generating an inspiratory flow that splints the airways and increases functional residual capacity, and it generates PEEP. It's delivered by light nasal prongs, and because high volumes of air are pushed into the airway, oxygen is diffused better than any other oxygen therapy. High flow, besides increasing the functional residual capacity, has also the ability to wash out the dead space, optimizing those areas of the lungs that wouldn't otherwise be able to participate in gas exchange. We are reaching the final part of this presentation, and I would like to present some of the essentials of caring for a ventilated patient. In a nutshell, we will attempt to cover two major aspects: safety and respiratory function management, and some systemic complications that may occur from being ventilated. With regards to safety and respiratory function management, I will refer to some of the rituals that should be incorporated to ensure a patient is safe from immediate danger of deterioration due to either a system or equipment failure. The best time to do this is usually around team handover. So during handover, basic observations should be made of the general appearance of the patient, sedation level, comfort, position, and any obvious pain. Immediately after handover, and there are two different types of management that can be done. One that is general, that is applicable to all ventilated patients, and other individualized, which will depend on the patient that you have in front of you. So for generally, the following checks should be done, like chest wall movement, auscultation of the chest wall, looking for secretions. Is the endotracheal tube size the correct one? Is it correctly positioned? And is it secure? Is the cuff pressure on the endotracheal tube appropriate? We can do pain sedation scoring to assess immediately if the patient is correctly sedated and pain-free, or as free as possible. Then as part of the individualized checks, and this has to be adapted to the needs of each patient, you can perform, for example, Glasgow Coma Score, GCS, as it is commonly referred to assess the level of consciousness of your patient. You may also be asked to perform arterial blood gases to know more about the patient's response to ventilation, amongst other things. You should ensure that your ventilation settings, alarm settings, were the same as as were prescribed or handed over. Your recent observations may suggest to the senior team that adjustments have to be made. You'll also observe the type of efforts that the patient is doing, aside the self-ventilating tidal volumes of the patient, both by looking at the patient and by looking at the ventilator. You can also check if the suction is in working order and perform easy suctioning if necessary. Finally, it is important to ensure that emergency resuscitation equipment is in working order for that particular patient. Provided that all safety and respiratory management function are maintained, there are issues around systemic complications that must be taken into account and known when you're looking after a ventilated patient. So the first obvious one is respiratory complications, such as ventilator-associated lung injury that we spoke about by providing too much pressure or too much volume to that patient that is receiving these large flows of air through a ventilator. Ventilator-associated pneumonia, these patients have an endotracheal tube, which is an invasive device, and they're at an increased risk of infection in their lungs. Increased work of breathing or hyperventilation. There are also cardiovascular impacts to ventilation that includes impaired venous return, decreased cardiac output, hypertension, and hypoperfusion. Edema due to venous congestions may occur, both as hormonal and enzyme responses to the fluid imbalance caused by the cardiovascular issues. The liver may also become affected due to diaphragmatic compression, portal vein congestion, and ischemia due to hypoperfusion. And all of this can cause a reduction in albumin production, poor drug metabolism, and impaired clotting. There are often neurological underlying problems which can be aggravated by ventilation. Your patient may be confused or delirious. And finally, due to all of the above and the presence of several invasive devices, there is an extremely increased risk of sepsis. Notwithstanding, supportive treatment of ventilated patients will also become ventilator-associated complication, even though it can be considered more generalized to all ICU patients. Your patient will be incapacitated with sedation, with sedatives, analgesics, and paralytic agents and muscle relaxants, which will increase the risk of deep brain thrombosis, nutritional deficits, and muscle wasting, which can last for months after discharge. Because patients will need invasive monitoring and central venous access, they will be at extreme risk of infection, namely bacteremia. Cardiovascular complications make them subject to the use of vasopressors, and related to the endotracheal tube or cuff pressure, these patients can develop vocal cord paralysis, laryngotracheal stenosis, or fistula formation. To finalize this session, I would like to summarize its key points. Mechanical ventilation is very often needed in the ICU. Hence, nurses working with ventilated patients need essential knowledge of the equipment and basic modes of ventilation used in their own units. It is important to say that ventilators may fail, so safety checks will always ensure patient safety in an emergency, and also that ventilated patients requires continuous monitoring of all systems, because positive pressure ventilation is not physiological and it affects all systems. Ventilated patients hence fully depend on nurses for fundamental aspects of care, such as hygiene, positioning, nutrition, mouth care, and communication. Thank you. Yes. Are there any questions?
Elsa. Thank you, Elsa, for that very informative explanation of ventilation and the differences between invasive and non-invasive ventilation and how to achieve safe and effective care on ventilation for patients. So I was thinking, if I were a non-ICU nurse, what would I need to know or be concerned about, as well as all of that really useful and beneficial information you've given me? And so I thought, if I were starting out on my first shift to look after a ventilated patient in ICU, what would I need to think about?
Thank you, Una. Yeah, that's a really good question, because I think that it's one of the first things that crosses your mind when you are not an ICU nurse and you are faced with the possibility of looking after a very complex patient, such as a ventilated patient in the ICU. So my advice would be to obviously have some essential knowledge about what is a ventilated patient and what's going on with that particular patient. And another important thing to know is each unit is different and each context is different and each setting is different. So it will be important to be familiarized, one, with the type of equipment that we are working with. And most units will have guides or guidelines that explain how the equipment works. And this is regarding the equipment, is familiarize yourself with the type of ventilator, because if you know the essential modes of ventilation and how they work, it is just a matter of understanding how they reflect and what they mean in that particular machine. With regards to getting to start caring for the patient, I think it's fundamental to make sure that you get as much information in handover as possible and ask all the questions to the nurse that is handing over, to the colleague that is handing over, to know as much as possible. Because if you know what happened in the previous shift, that is a very good way to prioritize your care and to know what is the normal for that patient and what should you be looking for in terms of deterioration, for example. So I would start with that, and I would just then, after this, start with doing the safety checks, checking the emergency equipment, checking if the tube is in the right place, checking if the patient is comfortable. If you ensure that all these things are taken care of, then it gives you a bit more time to plan your day and to ask any further questions to senior members of the team.
Thanks, Elsa. And then that leads me on to my second question, which I might be a little bit concerned about as well as a non-ICU nurse. To what extent are nurses in the ICU nurses themselves and the non-ICU nurses coming in to support them, to what extent are they involved in the changes of ventilator settings, if at all?
Yes, well, in order so we all know that in order to be an ICU nurse, you need a specialization, or you need some sort of specific training to work in the ICU, and that will then allow you to have more specific knowledge and more in-depth knowledge of all these issues around ventilation and other issues that will be discussed in this training as well. Just to be clear, nurses, whether they're ICU trained or non-ICU trained, will not by themselves change ventilation modes. However, this is a decision made by the senior clinical team, which may involve nurse practitioners or may involve the medical team, either more senior usually. So no, they won't be involved, or they won't change the modes directly, and that is not recommended at all, because it involves a more in-depth knowledge and a more complex knowledge of all other issues around that patient. And in terms of accountability, it is not in their role. However, all the information that they collect from the patient should not be underestimated to inform others who are more able to make these changes. So even though the nurse can't make the changes herself, it is important to not underestimate that any information, no matter how subtle or how little it may seem, from the patient, that she should convey to the senior team. And this is what nurses must be aware. It's not their responsibility to change the modes, but it's their responsibility to be aware of any signs that this must be done. And in case of doubt, please refer to a more senior member of the team or an ICU nurse who will be surely, hopefully, around.
Thanks, Elsa, and thanks again for your talk and your very in-depth answering of those questions. I think that would provide a lot of reassurance for nurses going into the ICU. Thank you.
Thank you, Una.